Good evening, everyone. This is Meldita, and I'm back here at my YouTube channel, Meldita's Info Corner. And this is my Facebook, joeregacho@yahoo.ca. Okay, posterior STEMI. This is a big heart attack or STEMI involving the posterior side of the heart or the back part of the heart. So that's the posterior side. Okay, so we have a case here of a 58-year-old male with a diagnosis of posterior STEMI. And his chief complaints are chest pain and left arm numbness. And he said that there was a sudden severe chest pain felt, 8 to 9/10, and there's a left arm numbness. Okay, these are the presenting chief complaints while carrying heavy boxes. Well, he called 911 and advanced life support crew arrived, and they did their first 12-lead ECG. Now, the machine interpreted it as an inferolateral STEMI, so let's take a look. So we have here the first 12-lead ECG. Okay, it's the basic one. So I'll try to locate the inferior leads, which are the lead 2, 3, and F. Do you see any ST elevation? For me, I do not see any ST elevation, none. Lead 2, lead 3, none. ABF, none. And lateral STEMI, that's what the interpretation made. So let's go to the lateral leads. Lead 1, AVL, B5, and V6. Well, I do not see any ST elevation. Maybe a little bit on V6, but it needs 2 to confirm the problem. Okay, I still should say there's no ST elevation on the inferior leads and lateral leads. Well, what caught my attention is this. There are ST depressions deep on the leads V1, 2, and 3. See, these are the septal. Okay, so if we don't have inferior ST elevations, because sometimes your reciprocal for inferior is anterior, but usually the reciprocal for inferior is, the lateral leads, 1 and the L. But in this case, we do have depression on V1, V2, V3. So is this machine interpreting it as a reciprocal for, inferior STEMI or inferior lateral? There's none, because I told you there's no ST elevation on the inferior leads. Okay. So anyway, that is the very first 12-lead ECG done. Okay, so what they did, they gave the patient loading doses of aspirin, ticagrelor, or Plavix. They are both antiplatelet medication. Okay? And then they also dealt with the pain using nitro spray for the chest pain, morphine sulfate IV. Okay? And if the patient desaturates, they can actually give oxygen, or even if your saturation is good, if the patient is in respiratory distress, you still have no choice but to give oxygen to the patient. Okay. So the risk factors so far here, we have here hypertension or high blood pressure, high cholesterol or DLP, dyslipidemia, chronic smoker. There was a previous small heart attack called non-STEMI, and they stented the RCA. Okay, we're gonna find that out, when the results of the angiogram comes out. Okay, there we go. So those are the history and some risk factors. Okay, so meantime, after 28 minutes, they decided to do another ECG, but this time they dropped the B4, 5, and 6 and proceeded to V7, V8, and V9. It's still the same. It came out to be ST depression, V1 to V3, but there is ST elevations, V7, V8, and V9. So we have here a posterior STEMI. These are the reciprocal. If we don't have these posterior leads, reciprocal, it's not enough to confirm that this is a posterior STEMI, because you have available leads to take, and all you have to do is attach extra electrodes to the back and do your V7, V8, and V9. So these are direct leads to tell us whether the patient has posterior STEMI or not. I don't rely on one factor alone. ST depression is not enough for me to confirm that we have posterior STEMI. It is a must that you have to do this one posteriorly because you have no ST elevation inferiorly. Okay, so true enough, the ECG reveals that we have posterior STEMI. Okay, so we have positive symptoms, we have positive elevations, but there's one more to prove, is the angiogram. Okay, so they did another ECGs here twice, and the same. The posterior leads, they remain to be with elevation. Okay, so they brought the patient to the cath lab, but patient will be placed for the time being in the whole bay, okay, while preparing the table. Okay, so in the whole bay, they had done 2 sets of ECGs here. So the basic ECG, and it is sinus, but the ST depression subsided a little bit, and that probably a little bit of help from those medications given earlier, like antiplatelets, and also, vasodilator, and some for venodilator, and some for, pain medication, and these medications can reduce the demand, but the antiplatelet, maybe it is off a little bit of any existing thrombosis if there is. Okay, so after that, they did another ECG 12 lead. No, it's not 12 leads anymore, because what they did, they added. So we have here ECG done, okay, until they did a 12 lead ECG here. We have it here, 6 and 6 in here, precordial leads, but they added here B4R. B4R usually is done if there is an existing inferior STEMI to prove whether we have an RV infarct or not. We don't have, because the ST elevation is actually is a little bit depressed. So there's no elevation on the B4R to prove that we might have an RV infarct. So there's no RV infarct, and there's even no elevation on the B4R. Okay, so there's none. Okay, there we go. And then they continued to check V8 and V9. And they remain to be elevated, V8 and V9. These are the posterior leads. So still the same. It's confirming that we have posterior STEMI, as I said, pending angiogram results. Okay. So then, an angiogram was done by the interventionalist cardiologist, and he found out that we have a blockage in the circumflex artery here and the OM. So he stented the CERT and the OM, okay, to create blood flow. Okay, now with regards to the old stent, it's open. This was a previous stent in the past for having a small heart attack. It remains to be open, so which is good. The ejection fraction is 40%, which is slightly low, and maybe this is existing because of the ongoing infarction, and the EDP so far is normal. Okay, so he ended up going to the CCU, and we did ECGs and everything, and we see that it's sinus rhythm. The ST depressions of B1, B2, B3, these are the reciprocal. We proved already that this is a posterior STEMI. It's very close to isoelectric line, which is good, but they did not do any B4, or they did not do any posterior leads. If you were to ask me, I will do it, but there's none. But that's okay. Our reciprocal is they're getting better. Okay. Then the succeeding ECG is the best. Okay, and we see that this ST segment on the V1, V3, these are the reciprocal, went isoelectric line. So, which is good. Okay, so